Hello, my name is Del-Carpio, a cardiac electrophysiologist at Mayo Clinic. I appreciate the opportunity to make this brief presentation about the role of the electrocardiogram in the area of advanced technological cardiac electrophysiology for the International Society of Electrocardiology. For the next several minutes, I want to convince, or perhaps better said, I want to remind you of the fundamental role of electrocardiography on the practice of modern cardiac electrophysiology. No doubt that the field of cardiac electrophysiology has experienced impressive progress in the last few decades. We have better technology, we have multipolar catheters, baskets, balloons, better ablation technology like irrigated catheters and cryoballoons. We have remote systems to maneuver catheters and avoid radiation exposure. Catheters that are able to register electrical activity from multiple sites inside the heart simultaneously. We are able to display these electrical recordings and analyze the characteristics and potential arrhythmia mechanism or the arrhythmogenic substrate from multiple sites at the same time. Those registrations can then be incorporated into a three-dimensional geometrical representations of cardiac structures and analyze the cardiac electrical activation sequences. For instance, in this case, the activation sequence of an atypical atrial flutter in the left atrium. We have better imaging techniques like the intracardiac echocardiogram. These images obtained can be merged with the mapping systems, and we can reconstruct cardiac anatomy. We can evaluate the anatomy of intracardiac structures more accurately. We can monitor catheter placement and ablation on these intracardiac structures in ways that we only could imagine in the past. Therefore, plan our ablation strategies of more complex arrhythmias with better characterization, better success rates, and potentially fewer complications. But let me remind you that regardless of the use of more advanced technology, the field of electrophysiology depends on this simple surface electrocardiography. In fact, this exciting field started with the electrocardiogram. Back in the early days, more than a century ago, electrocardiography was cumbersome. The first instrument was the capillary electrometer, with which the first electrocardiogram in man was recorded in 1887. At that time, a light beam interrupted the mercury column, enabled photographic records made on plates mounted on slowly moving toy train wagons. Because of the poor time definition, the recordings thus obtained required complex mathematical corrections to display the electrocardiogram as we know that today. But soon after, Eindhoven later developed the string galvanometer, a more sophisticated and more accurate system to record electrocardiograms. But still, the instrument was used only in physiology laboratories, and it was still burdensome to obtain. Look how these electrodes were used. Buckets filled of saline water in which the extremities had to be immersed. As this was a great invention, Eindhoven received the Nobel Prize for this invention in 1924. But now, and the last several decades, the electrocardiogram is widely available. From this bulky device weighing more than 600 pounds, requiring several people to operate it, and the development of negative photographs before the final tracing was available, it has progressed to ever smaller devices, mobile, and even we can obtain remote self-recordings. We cannot conceive a cardiac evaluation without the assessment of the electrocardiogram. We know that a picture is worth 1,000 words. Similarly, in the diagnosis of cardiac arrhythmias, an electrocardiogram is worth 1,000 words, since it can give you clues about the arrhythmia mechanism. In this slide, the top tracings show the initiation and termination of a supraventricular tachycardia. If you can observe, there is an acceleration and deceleration of the cycle length. It's the so-called warm-up and cool-down phenomena, making the diagnosis of a focal atrial tachycardia the most likely mechanism. The bottom tracing shows a different supraventricular tachycardia that terminates with a P wave, making the diagnosis of an atrial tachycardia unlikely. But the electrocardiogram cannot only be worth 1,000 words, it can actually give you the whole story. This electrocardiogram shows the onset of a supraventricular tachycardia, and by analyzing the onset and the actual tachycardia, we can precisely determine the mechanism of the arrhythmia. We'll zoom to the tracings from leads 2 and lead V1. This is a sinus beat with normal P wave and normal PR intervals. The third P wave has a different morphology, so it is a premature atrial beat that is conducted with a prolonged PR interval. And that is how the tachycardia is initiated. During the tachycardia, we can observe the so-called pseudo R prime in lead V1 and the pseudo S wave in lead V2. The mechanism is consistent with the typical form of a slow, fast, atrioventricular nodal tachycardia. But even if it happens that we don't have an electrocardiogram during an arrhythmia, a baseline electrocardiogram can still give us a good idea about the potential arrhythmogenic substrate. This is the case of a young patient with syncope and ventricular tachycardia that was documented during the first responder evaluation. And this is the electrocardiogram at baseline. A close look at the tracing, we identify these waves soon after the QRS complex in lead V1. This is called the epsilon wave, a marker of delayed myocardial activation in the right ventricle. The presentation and the baseline electrocardiogram is consistent with a disorder called arrhythmogenic right ventricular cardiomyopathy. During your invasive electrophysiology study, the electrocardiogram can help you evaluate for a possible complication. This is a patient who underwent a left-sided ablation through a transeptal approach. A few minutes after catheter exchange, patient complained of severe chest pain. The electrocardiogram shows ST elevation in the inferior leads, and a coronary angiogram shows tiny air bubbles in the right coronary artery. This is a diagnosis of air embolism. The electrocardiogram can keep you in track during your ablation case. This is the case of a patient with previous ablation for atrial fibrillation with recurrent atrial flutter. The flutter being mapped has a cycle length of 225 milliseconds. Flutter waves are positive in leads V1 through V3, negative in the inferior leads. This is the activation sequence with the intracardiac signals, and typically we would display more intracardiac signals than electrocardiographic leads. The mapping part of the procedure can be tedious, and you want to obtain only accurate information. After mapping for some time, this is the flutter being mapped, showing same cycle length and apparently a same intracardiac activation sequence. Without the information obtained from the electrocardiogram, we would keep mapping and obtain a misleading map that can misguide our ablation approach. In fact, the electrocardiogram shows a change to a different flutter, still positive flutter waves in leads V1 through V3, but there is an opposite axis in the inferior leads showing now a positive flutter wave. This is a completely different flutter. The electrocardiogram is fundamental to interpret many diagnostic maneuvers during an electrophysiology or ablation study. This is the case of a scar-related ventricular tachycardia. During an ablation procedure, we aim to determine critical areas of the re-entrance circuit. Particularly, we want to see if these slowly and abnormal conducting signals are part of the arrhythmia re-entrance circuit. We perform a well-known maneuver for the electrophysiologist called entrainment from this area, meaning that we pace the tachycardia and evaluate the response. How the tachycardia changes after this maneuver is critical information. This is the case of concealed entrainment of the tachycardia from the critical part of the circuit. The electrocardiogram serves because it tells us that the arrhythmia does not change during entrainment and that this particular location is an excellent target for ablation. In fact, the tachycardia terminates only a few seconds after radiofrequency ablation in the specific location. The electrocardiogram serves and is fundamental to other technologies. This is the case of an ablation of a ventricular extrasystole. It's a focal arrhythmia coming from the left ventricle. We're again using a mapping system, but the information collected in the mapping system to obtain this three-dimensional activation reconstruct is based on the timing of the electrical signals when we rove the catheter inside the heart and in reference to the surface electrocardiogram. The electrocardiogram gives us a global sequence of activation and represents a reliable reference point based on which the map is obtained. Let's not forget the basics. Modern electrophysiology was born after electrocardiogram. This tracing shows episodes of an incessant supraventricular long RP tachycardia that has consistently started and terminated with a ventricular extrasystole. It has this relatively narrow P wave positive in lead V1 and negative in lead 2. We now know that this is due to a particular type of a slowly or decremental and retrograde-only conducted accessory pathway, and the arrhythmia is called the permanent form of junctional reciprocating tachycardia. The electrocardiogram let us strive to think, and we can then predict. This is the case of a young female patient presenting with apparently two tachycardias. One is a narrow complex and other is a wide complex tachycardia. The narrow complex is definitely a supraventricular tachycardia, but soon after and during the same evaluation, it changes to a wide complex tachycardia. It's also supraventricular tachycardia with a right bundle branch block aberrancy. A close look at the cycle length of the wide complex tachycardia shows a difference of 30 milliseconds longer tachycardia cycle length compared to the narrow complex. This is the case of a right-sided accessory pathway mediated tachycardia that during the right bundle branch aberrancy, the reentrant circuit prolongs and leads to a longer tachycardia cycle length, or which is the same, to a slower tachycardia. We can then see that the electrocardiogram can teach us deductive thinking. This is a focal atrial tachycardia. The relatively simple analysis of the P wave, axis, and morphology can inform us to the probable origin of this focal arrhythmia. This of course can serve multiple objectives. We can plan our ablation procedure in terms of the type of approach, vascular access, risk of potential complications, etc. The P wave in this case is relatively wide, so probably it's not coming close to the septum. It is negative in lead V1 and positive in lead 1, so it's a right atrial origin, and it's positive in the inferior leads, so it comes from a superior part of the heart. So what would be a superior, anterior, lateral, and right atrial structure? This tachycardia is coming from the right atrial appendage. And in fact, the electrophysiology study confirmed a right atrial appendage tachycardia. The electrocardiogram keeps your target clear. You don't want to go into a procedure with an undefined target. This is the case of a patient with non-ischemic cardiomyopathy and at least 7 different documented ventricular tachycardias. Only the analysis of the electrocardiogram can tell you which ones you should target during your ablation and have a target that will make it more successful and potentially also carry less risk. The electrocardiogram is cheap and many times can avoid the use of expensive and unnecessary technologies. This is a recent tracing I was presented during a consult. A patient came to the emergency room with dizziness and multiple telemetry tracings showing apparently a paroxysmal wide complex arrhythmia. But a close examination of the tracings can reveal that, in fact, what is behind these wide complexes is a normal rhythm. The narrow normal QRS complexes can be marched out to the preceding and subsequent normal rhythm. This individual didn't need any specific therapy for a presumptive tachycardia. So let's not act as spoiled children thinking that we always need the last and most recent toy or technology. Technology is important and we should embrace innovation, but let's always keep in mind that an old technology as the electrocardiogram has an important role in order to provide optimal medical care. These are other reasons for the importance of the electrocardiogram. The oldest and most commonly used cardiovascular laboratory procedure, non-invasive and simple method to record. It is highly reproducible. It can be applied serially. Equipment and cost of recording are minimal. The only practical and non-invasive method of recording the heart's electrical activity. It is the first test in the evaluation of a cardiac patient, and is the gold standard for the clinical non-invasive diagnosis of cardiac arrhythmias. Let's also remember, and for those of us who have some time practicing, our mentors and teachers, and how much enjoyment and fascination we experienced the first time we were presented with remarkable electrocardiogram tracings that explain the underlying physiology of a determined cardiac disorder. Those mentors are in fact the people who made us love electrophysiology or cardiology, and we should pay some tribute to them. In my case, and hundreds of others, that teacher and mentor was Dr. Agustin Castellanos, who unfortunately just recently passed away. I don't know if I would be able to experience that fascination again to find out for the first time how much a simple 10-second electrocardiographic tracing can teach us about the heart. So I ask you the question, Is the electrocardiogram still valid in the area of technological cardiac electrophysiology? And perhaps this cartoon can suggest the answer. It is about Atlas that, according to Greek mythology, was condemned to hold up the sky for eternity. I think in some ways the electrocardiogram is also destined to hold up the advances in cardiac electrophysiology and, for the matter, cardiology. Finally, in the early years of electrocardiography, there was an English physician who took over on the advances of electrocardiology after Eindhoven. His name was Sir Thomas Lewis. More than a century ago, back in 1912, he said, "The time is at hand, if not already come, when an examination of the heart is incomplete if this new method," he was referencing to the electrocardiogram, "is neglected. We can tell without hesitation that more than 100 years later, this still holds true." Thank you.